G'day guys, Benjamin Morgan, Chief Executive of the Aircraft Owners and Pilots Association of Australia, and welcome to our AOPA Live panel discussion in which we have a very special guest with us. It was announced last week that we would be joined by none other than Dr Kate Manderson, who is the new Principal Medical Officer for the Aviation Medicine inside of CASA, and it is our great pleasure to be able to welcome her to this broadcast. We've had an interesting journey over the last 5 years with representatives from the Civil Aviation Safety Authority. And before we get going into tonight's discussion, I'd like to put it out there that we see this as a really important step forward, not only for our relationship with CASA, but also on behalf of our members in representing their pilot medical concerns through our pilot medical review panel. It's critical that we do have a working relationship, and it's one that's based on mutual respect. And we're really impressed that Kate has taken the opportunity as the first CASA PMO to join us in a live panel discussion and to take questions and comments, of course, from the aviation industry. And on that point, I'd like to put out there that Dr. Kate comes to us this evening in a very open way to talk about her joining CASA and how she sees the situation across aviation medicine. It's an opportunity for us as an association and also our collective membership to be putting forward questions in a respectful and polite manner. And I really encourage everybody this evening to look at this as the opportunity that it is and refrain from putting forward any comments or questions that would be offensive or in some manner disrespectful. This is a great engagement, and I really do personally hope that this can become a real recurring theme and a recurring setup here with AOPA, because we'd love to be able to introduce more of the senior leadership of the Civil Aviation Safety Authority through to our members and industry, because it's through robust conversation and debate and discussion that we're actually able to highlight issues and get things moving. So with that said, I'd like to welcome Dr. Kate. Dr. Kate Manderson has started her career in aerospace medicine in 2001 as a junior medical officer for the Royal Australian Navy, which I learnt this evening. She has completed her postgraduate studies through the King's College of London and the Royal Air Force, and went on to become a Foundation Fellow of the Australasian College of Aerospace Medicine. Dr. Kate is also a Specialist General Practitioner and a Fellow of the Royal Aeronautical Society and the Aerospace Medical Association. And I welcome Kate to the program. G'day, Kate.
Good evening, Ben. Thanks very much for giving me the opportunity to be here with your members. Really grateful for that.
Well, no, I'm grateful for it. And it's really exciting that we're able to pioneer like this and to bring this communication forward for our members. Dr. Kate, I'll refer to you throughout the program. Dr. Kate, I've known you now for a while in the work that you've done on behalf of industry. You've effectively been on both sides of the fence. You've been an advocate on behalf of industry, and now you've found your way inside of CASA, a new role and a new outlook on some of the challenges we face as an industry.
Yeah, look, it's I guess it's a different perspective, that's for sure. And some people might suggest I've turned to the dark side by going into the regulator. I see it quite different to that. I think we are all part of the same industry, and our interests are actually quite shared. And I think my new role as the PMO of CASA is just an extension of what I've been doing previously with Defence, with ASAM, with the Society, and with doctors. So I think it's just a natural progression that we're doing this all together.
Well, thank you for joining the program, and also joining us this evening are some of our regular AOPA contributors, and none other than Director Dr. David Hooke. David, welcome back to the program for the first time in a few months.
Good evening, Ben. Good evening, Kate. It really is a delight to have Kate taking up the position of PMO, and I think we're going to find it a breath of fresh air, and it's lovely that she's able to join us on the panel this evening.
Well, someone that has effectively been there from the start of our pilot medical review panel at AOPA, and you've been actively involved in quite a few number of member concerns that have been passed through to AVMED. You and I, David, have been able to have some conversation of recent, and we both agree that there's a really unique and new opportunity here in Kate in this role. So I'm sure we're going to have some great conversation this evening. Now, we're also joined by AOPA Director, Dr. Sean Runacres, and Dr. Sean Runacres is an extremely well-known DAME based out of Moorabbin in Victoria, and he recently joined the Aircraft Owners and Pilots Association to take on the lead role in managing our pilot medical review panel. And so welcome, Dr. Runacres.
Well, that's a bit formal. Thanks for the welcome, Ben, and really want to say welcome to Kate as well. Thank you very much for making the time to be here. It's fantastic.
Okay, so what we might do, Kate, is we might hand over to you and give you the floor. And I'm sure we'd all love to hear a little bit about your background and I guess what's brought you to CASA. And then from there, we might start taking a few comments and questions from not only the members and industry supporters, but also from our panelists. So over to you, Dr. Kate.
Thanks very much, Ben. So I guess by way of background, I mean, you've had the official spiel about who I am and what I do, but I guess I got dropped into aviation medicine, in fact, not really knowing what I was in for, and look at me now. I was given the option to post to HMAS Albatross as a junior doctor back in the day, and it was just a better option than Cerberus down in Frankston or over in WA or up in Darwin. So, okay, I'll go to Nowra. That sounds nice. It's down on the coast. And from there, the Navy was generous enough to sponsor me to go and do the aerospace medicine training over in the UK, which was just extraordinary. And you know, all the good things come to an end. I've transferred to the reserves now, but I continue to serve in the Navy. But I've had the opportunity to work in regulation to a certain extent at the RAAF Institute of Aviation Medicine, and of course as the president of the Australasian Society of Aerospace Medicine. So really interesting opportunities to get into things, the leadership and the governance and the advocacy space in AvMed, not just the clinical management. I continue to be a practicing GP, so that, you know, still a clinician, but governance and leadership is a big part of what I do these days. But I try to bring to each of those roles still that concept of being a doctor and being a GP. I'm a very passionate GP, and it's about communication and collaboration and bringing people along with you. Sometimes in medicine, in general practice, in aerospace medicine, we tell people things they don't want to hear. We tell people they've got cancer. We tell people that they can't drive their car anymore. You know, an elderly lady can't drive to the shops anymore because she's got dementia. It's really hard. But what I found in over 20 years now of general practice and almost 20 years of aerospace medicine is that sometimes the message is not what you want to hear. But often the way the message is presented and the way we manage the expectations and the way we do it with kindness and respect, we do it with collaboration, that's what brings the goodness out of it. And that's what I want to bring to my PMO role. And notwithstanding any of the people who've come before me, this is me, this is my approach, and it's going to be different to what other people have done. But this is what I bring to it, is a sense of collaboration and communication and cooperation. And I'm not always going to give you everything you want. I'm not going to say that everyone can fly every time. But what I really want to do is to maybe bring some of the news that you don't want to hear sometimes, with kindness and compassion and empathy and respect, to make that a positive message no matter what it ends up being. That's why it's so important that I'm here tonight. I've had the opportunity to have a similar conversation with the team at Virgin Australia, with some of the Qantas Group pilots, and coming up with the Qantas mainline pilots as well, to talk about the fact that, you know, the door is open, that we want to collaborate, that we want to work together. That's the crux of where I'm going to with this particular presentation tonight, and with my position as PMO. I want to work together with everybody.
Well, look, Kate, it certainly is a challenging environment to work in, and you know, I've been with AOPA for almost 6 years now, and in the time that I've been with AOPA, we've touched on a multitude of AvMed issues on behalf of members, ranging from incredibly minor details through to some of the most complex medical cases that I've seen in aviation. Situations where, in some cases, some are frustrating because it's like, you know, why is that a problem? You know, when you've had other cases that you look at going, wow, that was so much worse, and yet the one that was easier didn't seem to navigate through very quickly, but the one that was so much more complex actually found its way through much faster. And it became part of the genesis as to why AOPA formed its pilot medical review panel, is that we really needed to find a way to bring together aviation medical specialists to work with members because they were finding it very difficult to engage with admin. And I think it is very important that we do say that this evening, and we're honest about these things, that there has been a historical difficulty with people working with AVMED. And I think communication is a big thing. I think being able to move towards an outcome where pilots across the industry are getting responded to in a really prompt and efficient way, and that the information has clarity, and that the processes can be made clear and concise for people. What I might do is I might throw over to David Hooke and maybe just get some reflections from David on our work across the last 5 years, and also your experience, David, with AVMED and some of the challenges that you're seeing, and then we can put some questions to Kate.
I think, thanks, Ben. Just listening to your comments there, Kate, one of the things that resonates with me was the management of the expectations of pilots. And as you know, I was dealing with the heading up the review panel over the last few years. And it was interesting. Some of the pilots knew that they weren't going to be able to fly. They were having a crack at getting their license back, but their expectations and their common sense told them that they were not going to be able to get it. And really, some of those pilots, all we had to do was reassure them that they weren't going to get their license back, that they had a sufficiently significant clinical problem, and it was simply confirming their expectations. So it made sense. The other pilots, on the other hand, had expectations that they would get a medical, that their problem was minor, that it was of no great moment, and it made no sense, as distinct from making sense, made no sense for them to be denied their medical. And so I really hear what you're saying about the management of expectations. And I think part of that is making sure that we don't make decisions which simply make no sense to anybody at all, but comply with some bureaucratic rule. I also love the thought of improving the collaboration and communication rather than the delivering an ultimatum from on high. Pilots are pretty motivated. They haven't got where they've got by being silly. They will listen to reason, and when they get an explanation of why something that they thought made no sense at all, then they'll take that on board. So again, it's a combination of collaboration, communication, and the management of expectations.
Dr. Kate, I'll throw that across to you. There's a little bit to unpack in that.
Yeah, no, for sure. But that's that's a critical thing, and the concept, things like comparing. But that guy had a condition that was the same as my condition, and he can fly, but I can't fly. It doesn't make sense. Having the opportunity to sit down and explore the why of a decision. If the letter from AVMED says, I'm sorry, it's just not going to work for you, the why, and let's sit down and talk about what is different about your case to that other guy, that it's not apples and apples. In fact, there's something different going on here. Why has this decision been reached? What did we look at? How did we come to that decision, and what does that mean, and where to from here? And is there a chance to have another look at it down the track, and so on? That open dialogue, that open communication, and that understanding why and understanding how and understanding the background behind it, not just this.
I think Kate's just frozen in time.
The black box happens, and we spit out an answer at the end, right? I want there to be an understanding of the why. And a really critical thing that I want to get across, and I share this with my Defence Force friends as well and colleagues, is that it would be really easy for us just to apply the AKO rules and just say, you know what, you got a condition, you're done, you're out, end of. We have the flexibility rules. We have the opportunity to say, no, but in this case, maybe we can, maybe we should. If we get a bit of this and we look at that and we have a think about this and we have a safety pilot and we look at, altitudes, and we look at aircraft and we look at operations, in fact, we can find a way to make this work. And that the concept of find a way to yes, if there is a way that we can find it, we will do what we can to find it. Now, sometimes we won't, and sometimes the answer is still going to be no, but we will look at all of the ways we could make that answer yes. And we will talk to you about what we've looked at and why we've looked at it and how we've looked at it and why we looked at this and not that and what else we could look at and what do we need. Looking at all of those things and sharing that and talking about that and finding that way, if the way is there to be found, and bringing the pilot and their DAME and their representative organisation like AOPA along with it. So it's not some black box where random stuff happens. It's actually a clear collaborative process. That's what I'd really like to be achieving with some of the things that we're going to be bringing out of CASA, hopefully.
So obviously Kate's fresh in that role, and Kate, you've just touched on a subject which I've spent a huge amount of time working with Dr. Runacres on. And that is because Sean, I'll call you Sean because I'm used to calling you Sean. It sounds too formal, but Sean and I have spent we've spent a lot of time working with each other on various member concerns, and a recurring theme. And again, I say this, and it's not in reference to you. You're only new to this position. You're inheriting a lot of this, but a recurring theme in this, Sean, is that a lot of work goes on behind the scenes to put together specialist reports and to gain a broad sense of material to represent the individual's medical situation. And we're finding it very difficult that much of that information goes into the system, but then it just either gets ignored or it's being overruled for further information. I mean, you have that frustration, Sean.
Yeah, I do. It's a regular frustration, and Kate, just a little bit of perspective. I do about 350, 400 pilots a year when we're not in COVID time. So I'm busy doing this on a regular basis, and I have some idea about what's going to get through and what's not going to get through. And the transparency has been lacking for a long time. And some of it's simple stuff, but some of it just doesn't make sense. When I get a couple of cardiologists or a couple of neurologists who say, the risk in this is low, but there is no literature to support my opinion, and CASA just says, no, we can't do it. It's very hard for me because all I've got is a no, and the transparency. So if I try and ring up and get an explanation, 99% of the time I get stuck with the assessors on the phone and I can't speak to anybody. And so I have to go back to the pilots and say, I've rung up, I've asked, I've messaged, I've asked, but I can't actually get an answer for you.
Okay. Clinton McKenzie has just put a question or a comment up. He says, I do laugh when I hear a bunch of doctors discussing who can and who cannot fly. I suspect that a bunch of doctors would laugh as much at a bunch of lawyers discussing who can and cannot fly. You're expressing an opinion. Much of the difficulty we face as pilots is CASA AVMED doctors who consider their opinions to be objective truths. He raised a really valid point here, and it's a discussion, Kate, that you and I have had, and I've been seeking to try and understand from your perspective how you view this particular issue. But we do have a situation where we've got quite a history of pilot medical cases that have navigated their way through the system, where we do have highly qualified specialists in their field, people who are immensely respected within their particular field of medical study and discipline. And when they're putting an advice to CASA, quite often those advices have been overruled or declared insufficient in order to advance the case. I mean, obviously, I understand you can't give an answer as to the specifics of a case, but generally, what's your thoughts on this type of concern?
So this comes to the concept of risk assessment and how do we assess risk, and what information do we use to assess risk, and it's the principle of the practice of evidence-based medicine to a certain extent. And we do this every day in medicine and in general practice. I do it all the time. So I've got a patient in front of me with a particular situation and a particular problem. What I've got to work with in figuring out how to help this person with their problem, which medication or which treatment option, what I've got for this person, I don't know what's going to work for them. I truly don't know. What I know is what generally works for most people in their situation, and that's the literature. That's what the TGA is approved for certain medications, or the College of Surgeons has recommended as a procedure. In most cases, in most patients in that situation, this is the treatment that works. And I don't know what's going to happen for this person. And the aeromedical risk assessment and the decision-making process is very similar. So I have no idea what's going to happen for this person in this case. And it may be they're going to be absolutely fine, but I don't know that. And I don't know the likelihood of something going wrong for this person. What I've got to go on is what generally happens for most people most of the time. So we've got to figure out, is the generally happens most people most of the time, where we've got a global body of literature and evidence that indicates what will usually happen, and then we've got an individual assessment by an eminent specialist based on the case that's in front of them at the time. And that's, if you look at the NH and MRC hierarchy of evidence, that is that's the sort of level 5 evidence that is an individualised case review and assessment of risk for this person. And then we've got the rest of the hierarchy, which is the global consensus view for most people in the same situation, where we've got 100 people or 1,000 or 1 million people in the same situation. So is it the one case that we go on that we think they're going to be okay? Or is it the consensus view that we go on that, generally speaking, the literature says they will or won't be okay? Which one is the one that the CASA risk appetite sits with? And this is it's a really difficult question, because on the one hand, we don't know what's going to happen. We could see what happens, and the only way we're going to know that we were right is in retrospect, that we got away with it. Or we've got the global view that we see that in retrospect for all of the other people, this is what happened. Which one do we go with? And that comes back to a slightly different kind of conversation about the risk appetite and the risk appetite of the organisation. And this was a really interesting conversation that I sometimes have the chain of command, and is it up to me to decide, and so on. There's a whole organisation behind me, and I love that some people may think that I am so powerful and so important that it is entirely up to me to decide. There's some other stuff going on in my world about whether or not there's enough doctors in the Shoalhaven, and there's some people who think that I am the only person who's responsible for deciding. And I think Minister Greg Hunt would, let's say his name carefully, Minister Hunt would disagree that I am the most important person. And similarly, in CASA AvMed, it's not actually all about me, as much as I'd love it to be all about me. It's not all about me. It's the organisation and the risk settings and the risk appetite. And that's a conversation that I'm actually having with the senior leadership people coming up in the coming days, actually, about where is that set? Where is that appetite? Where is it set? Why is it set there? Where does it come from? What is the driver of that setting? And how does that influence the way I do my job and the way I support the other doctors to do their job? So clearly it's not as simple as what one doctor says over what a study says. There's so much more to it than that. But this is a really important thing about the communication piece. If we say the position of CASA is that the answer is X, this is why the answer is X. This is because this is the risk settings and the drivers and the appetite and the discussion, and it might be about global consensus. It might be about compliance and the obligations under ICAO and that kind of thing. It is broad and it's complicated, and it's not as simple as whether or not Kate says yes or no. I'm not that important as I'd love to be, but I'm just not. So there you go.
Can I pick up on, Ben, if that's okay, if I could pick up on the risk appetite? Sandy Reith's comment there about the fact that he's able to drive his car on public roads. And we've had similar situations in the past where somebody's quite capable or licensed to drive a B-double on the roads, and if he were to have an event he's likely to cause much more trouble driving his B-double than he would driving his little Cessna in outback New South Wales. And the same applies to RAOs. We've got the situation where a pilot misses out on his AvMed certification, and so says, "Oh, okay, I'll get out of the system and fly a small aircraft and fly under RAOs rules and self-certify my pilot, my medical." And it's and this I know is opening up a whole broader conversation about risk and the dichotomy between RAOs and AvMed. I'd be interested in your comments about that.
Yeah, look, I think that it's a common point that's brought up. I can do this in this vehicle in this context, whether it's a RAOs or it's a glider or a parachute or a B-double or a boat, and I can't do this in this setting or something else. It is about, where do the settings come from? What are we okay with? What are we okay with? This is really existential. As a community, as a society, as a culture, what are we okay with? And it occurs to me that it's actually quite similar to, sorry to go there, COVID vaccines. So my daughter is unwell, right? She's got a complex disease that means if she catches COVID, she will end up in ICU. So they're very rare for children to end up really sick. So my daughter's going to be one of those. And I want to give her the vaccine. And I've got a fridge full of vaccines and I just want to give it to her straight away. But the TGA won't let me. Now, we've got a body of evidence, we've got literature, we've got a bunch of stuff that says it's probably going to be fine, but they still won't register it for kids under the age of 12. So the 5 to 11 kids, they won't let me do it. The FDA won't approve it yet for the kids, but why not? The same body of evidence was available for the 12 and over, and we're good to go. At that level, we're not happy to do it for children. Why is that? For the little kiddies, why is that? And it's because there's something about the way we're put together that we just don't want to take that risk with the little kiddies. We want to be extra safe and extra careful and extra different, because there's something about our cultural appetite for risk that we just won't. We're happy to compromise the health and well-being of adult males and give them a Pfizer so they end up with myocarditis, but we're not happy to do that to a 7-year-old child like my daughter. Why is that? And that's really that's conversation for a glass of wine kind of stuff. Why don't we experiment on the children? Why don't we tolerate that risk with the children? Why do we allow us to have a risky situation on the road behind the wheels of a truck, and we won't have that same person at the controls of an aircraft? Why is that? What drives that? Why is our appetite so different in different contexts? And that's that piece that I really need to understand from the senior leadership levels at CASA, and that's what I've asked them to do. Please talk me through this. Where are the risk settings and why are they there, so that when I'm representing the organisation, because that's my job, I know where that's coming from and I know why I'm saying what I'm saying. One of the things when they interviewed me for the job was, how do I deal with having to do things that I don't agree with? Well, mate, I'm in the Navy, so I do a bunch of things I don't agree with. I give advice to command, and command ignores my advice, and that's okay. That's been my job. So I may actually decide, I might think that, you know what, I actually think that this is quite a reasonable approach, and we ought to consider giving this particular parameter a different risk profile and allow that to go ahead. And you know what? The boss is going to say, thanks for that, Kate. No. Okay, she's the boss. That's her job. She's the boss. So then my job is to maybe advocate, maybe say, but no, really, can we talk about this? And if the answer is no, the answer is no. And then I say, yes, ma'am, that's the answer. And then I help to apply that and understand that and navigate that and deal with that. So again, I get back to the fact that as much as I'd love to be the most important person on the planet in AvMed, I'm not. I am part of the story, but I'm not the sum total of the story. And part of my job is about understanding those risk settings and why they're there. And if the answer is, if the direction for me from the leadership who have a higher pay grade than me is that this is how it's going to be, part of my job is to then deal with the fact that that's how it's going to be, and work with AOPA and work with Qantas and Virgin and RAOs and everybody else about the fact that that's how it is, and try to make that as good as it can be. Hopefully that answered some of that story. I'm sorry, I can go on a little bit. Sorry.
No, that's okay. And I think a recurring theme in this, and something that you and I, Kate, have had an opportunity already to spend probably a couple of hours over the process of a few weeks talking about, is that a lot of this centres on exactly where the understanding of risk needs to be. And I think from an AOPA perspective, I'm going to hand this over to Sean to follow up on this point, but from an AOPA perspective, what we see is it appears to us that the risk profile and the subsequent AVMED requirements and assessment that have been applied to the private pilot community are almost carrying a legacy of the commercial world, and there is quite possibly an over assessment of private pilot medical certification occurring, and that in itself is creating a nightmare that then has to be managed. And I think, Sean, I will throw this to you at this point, because you do handle many of these on an annual basis, and I know David will probably be nodding along, and I know there's already a lot of comments that are touching on this. What's your reflections on the current risk setting for the private pilot medical certification? Do you think it's fit in its current form, or does it need an overhaul?
There's a couple of things in that. I think the first thing is you have to, I have to acknowledge that I make money out of doing Class 2 medicals. So not that I think I'm biased, but you have to be aware of my my thought processes, I guess. I do think that we over-regulate the Class 2 pilot. When you have a look at what most Class 2 pilots do, they don't do a lot of flying. I mean, you've got your instructors who are flying on a Class 2, but little hobby pilots like myself and their Tonka toys, they're lucky to be doing 50 to 100 hours a year. So yes, if they've got a higher risk profile, that needs to be looked at. But when you look at the number of hours in a year that they could actually be flying over the MCG and parking appropriately, it's actually quite low. There are two things that I want to talk about with regards to, like, for example, the safety pilot. So on one hand, for many pilots, that's a grounding. And I think in some respects, CASA looks at that as, well, you can still go flying, but it's not, if you're living out in the middle of nowhere and you're just flying around in your local area, that is a permanent grounding if you're having a safety pilot. Having said that, we turn it on its head. I think there's a reluctance to provide the safety pilot in the more, in probably the higher risk patients, where actually the safety pilot is okay. If I can get in a plane and physically get into a plane and sit next to an instructor, why can't I get in a plane and sit next to another qualified pilot and fly the plane? I think there's some issues around sort of that risk stratification there. And then you look at the Class 2 basic, going back to that sort of driver's license medical. I don't see it as fit for purpose in Australia. I don't do them, but essentially I get people ring me up and they go, oh, look, I'm having problems. I'm not convinced I'm going to get a medical or whatever the case may be. So I want to do a Class 2 basic. And I'm like, unfortunately, a Class 2 basic isn't, I've got a driver's license, I'm good to go. It's designed for the 16-year-old, never had a problem in his life kind of young pilot who just wants to start the learning process as cheap as possible. For somebody who's, collected a few extra birthdays, that doesn't work. And realistically, if you've got a pilot who's not safe to fly, then almost anybody is safe with a safety pilot. I don't see any scenario where a safety pilot doesn't tick the box. And if we look at the Class 2 basic, we need to make that much more fit for purpose, where there's a lot more fluidity in a GP able to make that decision on the healthy kind of person.
Dr. Kate, I'll throw that back to you, and what I'll highlight, there's a question that's actually come in from Gary Hill, who is an AOPA Australia member down out of Victoria, and Sean, you would be familiar with Gary. It says, Dr. Kate, why does AVMED override advice from a specialist who consults to them? His recommendation to provide a medical requiring a safety pilot and to instead reject the medical. And this is actually one of the AVMED cases that we've actually elevated up the chain, and it will be one that I follow up on. I'm not asking you to respond to Gary specifically, but generally the concept of moving towards a more rational system where if we have got pilots that are facing medical challenges where when an example might be that we have a pilot that has to have a pacemaker and a defibrillator, if I say it correctly, and globally aviation medical or aviation medicine standards for regulators are not too clear on whether these people can participate in a solo sense. What are the restraints that are stopping CASA moving towards a more progressive system where we would automatically issue a safety pilot limitation so that they can continue? And I believe that is an important question, because there's a lot of people in general aviation and recreational aviation and their identities. They're part of the fabric and the matrix of aviation, and they're out there encouraging people to get involved. They're a great part of that social scene that helps us bring more people into the industry. And we, of course, don't want to be losing them. We want to be harnessing these people. How do we move towards those types of outcomes?
So I think to speak to the question about following the advice of an individual clinician about an individual case versus applying the evidence-based kind of global consensus approach. If the literature says out of 100,000 pilots with that situation, this is what we should do, but the clinician says for this pilot in this one case, this is what we should do, why don't we listen to that one? And one of the answers to that, and we've got to acknowledge that every single case is different, and that's its own challenge. But one of the answers to that is the idea of consistency. So if we have been directed in some cases by the AAT, so legally told, no, this is how you've got to do what you do, and that answer has consistently been to follow the literature, so the meta-analysis and the 100,000 pilot journal article review of things, if we've been told that's how we've got to do what we've got to do, then that's how we've got to do what we've got to do. If we then say, well, you know what, I'm actually going to ignore that because in this case I want to do something different, well, then we've got inconsistency. And I think that's a pretty important thing, is that one of the things that we all value is consistency. If we're going to apply a rule, we apply the rule and we apply that approach consistently, and not just pick and choose the ones to whom we apply that depending on whatever's going on in that case. So, you know, it is the classical wicked problem. There is it's very difficult to tease out the correct answer in every case, but consistency is a really important part of that. So why do we not follow the advice of an individual clinician, and rather than that we follow the advice of the consensus and the literature and that kind of thing, and the higher levels of evidence? Is because that is the consistent approach, and we want to be consistent. That's probably the best I can offer in that space. One of the things that we want to be doing is bringing that clarity to each case. So if someone says, but that guy in that case got this outcome, you know, the Privacy Act stops us from sharing all of the nitty-gritty details of the other guy's case and why it was that was a different outcome. And unless we can get consent to share that kind of stuff, it's a little bit harder. We do need to just describe and discuss and explain and support the understanding of why it is that we've reached this outcome in this case this time. That's not going to be the same necessarily as the other guy's outcome, because not every case is the same. Again, like I said before, this is one of those risk settings, and do we go with the individual clinician's opinion on this case, or do we go with the consensus view that's based on literature and evidence? Which one is the setting that is appropriate, generally speaking, across the board for a consistent view? And it may be the case that the new DAS actually says, you know what, Kate, I actually want you to do an individualised risk assessment in every single case. I want you to ignore the global evidence and just do an individualised assessment in every single case. If that's what we're told is the new setting for risk assessment, well, we're going to work with that. It will take a very long time to get your medicals through if we do that in every case, every time, but that's okay. That's the challenge. Yeah, sorry, I've gone off a little bit. Please bring me back on track.
No, not at all, Kate. And we really do appreciate the open and fluid conversation on the issue. And I really do think that this is actually very important, because it's also about trying to develop an understanding of the broader thinking that goes into this. And there's things that I'm hearing from you this evening that are also informing me, as to how I maybe need to go about some more of my advocacy to make it a little bit more effective. I want to make a comment generally about some experiences of our members, and I'm going to throw this across to David, and that is, excuse me, when a member runs into a problem with AVMED, and it does become a situation where AVMED arrive at a determination and become very fixed on that determination, it's almost as if the roller door comes down, and the ability to work with AVMED in terms of a negotiation on behalf of the pilot and on behalf of the regulator to work to reasonable outcomes, it almost appears that there becomes a moment in time where the roller door drops and no further effort can be engaged to try and resolve matters in a way in which it then avoids the ultimate outcome, which is our members then having to go to the AAT at considerable cost and considerable expense to challenge an issue. Now, we've got quite a few examples where members do go through that process and they're successful. Those processes could have been entirely avoided by creating a better pathway, a better engagement. And I think it harkens back to what I'm hearing from you, which is that this has got to be about communication. It's got to be about an engagement, a deeper understanding of the facts. And I listen to you when you're saying maybe there needs to be a process where there can be individual assessment rather than the group assessment, because this is actually a really vital part of what undermines and damages the relationship between industry and regulator, is when we have pilots across the country that suddenly are exposed to spending tens of thousands of dollars because they want to keep a recreational or private medical. And again, that harkens back to this discussion on risk, that is the risk profile sufficient that we would create these outcomes, which in themselves create work, create a whole bunch of nonsense around it. David, I know that you've handled a few of these within our organisation, and it's resulted in members having to put to the cost. What are your thoughts on that?
Well, just before I, thanks, Ben, just before I comment on that, I just want to make a broader comment on consistency. And I take what Kate's saying about consistency among cases, but the point I was making before, and there was a comment from David Pilkington that suggested that I didn't make myself clear. I'd like to see some consistency across the airspace. It doesn't seem to me sensible that a pilot can be scrubbed out of a PH-registered aircraft, but then go down to his local airfield and perfectly satisfactorily engage in aviation in the same airspace without any problems. And the same occurs in the United States. There are, I think the last figure I saw was 37,000 pilots on self-certified medicals there, and there has not been an avalanche of accidents or bad outcomes, and so that's a broader look at consistency, and I would be interested in what Kate has to say about that. But I'll just talk briefly about the roller door at CASA, and I don't want to say too much, except I just want to say how I suppose we felt that Simon May initially when he first started was a breath of fresh air. He came in with a lot of common sense approach, and I think that it's unfortunately I think he was ground down by the bureaucracy and the organisation, and finally left. And we hope fervently, Kate, that doesn't happen to you.
So do I.
And I think the roller door is to do with communication. And it's a matter of not having, and you've expressed it already, not having a godlike complex to say that something which is an opinion is a true fact. A lot of it we know that a lot in medicine is not objective. It is subjective, and it's based on your previous experience and your knowledge and your reading and as you know, randomized controlled trials and so on. But it's not set in concrete. And I made this comment to David Pilkington one day, and the same applies to engineering. I must say, I thought engineering was like mathematics, that it was set in stone, everything was objective, but that's not the case at all. And medicine, some of it is, by the very nature of it, subjective. And I think that as long as we can keep a conversation going and try to inject common sense into our decision making, and again, aim for consistency across ICAO, with the US regulations, with RAOs and VH registered, the flying of VH registered aircraft, then I think we'll go a long way to solving the problems and not upsetting the expectations of our pilots.
Before I throw it back to you, Kate, for any comment on that, and I'm going to jump over to David, and I'm very cognizant of time. We only had you for a very short period of time. We're 46 minutes in. We're getting a lot of comments and questions that have come through. What I would like to do with those comments and questions after the broadcast is I'll copy them into an email and I'll share them with you, because I think it's important that you can take a look through that material. And obviously, I'm not asking you to respond to each of those individually, but if there are any points that you would like to respond to, AOPA would invite that and we can circulate that back to members. And we would appreciate, obviously, any time that you take for that. I also just want to make it clear that we're also cognizant that you are not the ultimate decision maker, and I don't want to be providing any impression that we're in any way placing a demand on you. And I did say this at the end of my last broadcast, that we're very fortunate at this time that the Civil Aviation Safety Authority has a new Director of Aviation Safety that we're really behind at the moment. We really feel that Pip Spence has both her heart and her corporate mind in the right direction with the Civil Aviation Safety Authority at this time, and we're really behind her. And I think a lot of these conversations we would like to open up to her as well in the right forum and the right setting to get her reflections on it. But I don't also want to place you in a situation as well where you're feeling like we're putting any undue pressure at this point in time. But David raises some interesting points there. Is there anything you'd like to reflect on before I throw over to Sean?
I suppose while you were speaking there, David, I was thinking about one of the things that kind of planted the seed for me for the concept of the collaborative approach. And it was, I don't know if you were there at the ASAM conference in Queenstown, where we had a presentation from one of the European regulators about something that they have done that I hope to be doing in the coming weeks or months, which was bringing in an opportunity for the applicant, the pilot, and the regulator and their DAME and perhaps someone else, an advocate or something, to sit around a table and to talk about it and to talk about what happened and why it happened and how it happened. So rather than a roller door coming down and saying, stop calling me, we say, no, call me, come in, and I want you to come in, and I want you to sit down, and I want to go over this together. And if it's a hard issue, do you know what? Let's dial your cardiologist in as well and talk about where we are and where we've gone and where we're going. And what they found when they brought that in, I think it might have been a military context, but what they found when they brought that in was that the level of satisfaction of the applicant, the pilot, was so much higher. The number of AAT equivalents that came up was so much lower. Now, the outcomes weren't that different. The decisions pretty much stood, but people were comfortable with the understanding of what happened. People were comfortable with the why the decision was made because they felt part of it. You know, it's agency, it's advocacy. And we didn't suddenly make people fly because when the decision was not, or we didn't remove the safety pilot, for example, when the decision was that, but because they understood the reasoning behind it, the satisfaction, the level of comfort, the general kind of engagement was so much more effective. And that kind of concept, now bear with me on this, and I promised the leadership team I wouldn't make any amazing announcements tonight, and I'm not doing that.
We're ready for we're ready for that self-certification in G8 anytime, Kate. We're ready for it.
Calm down.
Only the four of us.
Okay, so this thing the psychologists say to me, right, you cannot eat the whole elephant at once. How do you eat an elephant? One bite at a time. This is one of the things that I'm very much looking forward to doing, is having the opportunity to go over complex and challenging cases with the applicant, with CASA, with their DAME, with an advocate, and it may be one of Sean's team in the medical review team at AOPA, to understand what's happened and why it's happened and how it's happened. So, lift the roller door a little bit. And I can't promise it's going to change your decision, but what I do want to do is make it so that you feel like you're part of the decision and you're not just being told on high, I'm not that tall, trust me, on high, that this is how it's going to be. It's collaborative. That's what we want to be doing with that. So I think that's probably the thing that was going through my mind when you were speaking there, David. I hope that helps with the roller door, maybe ease it up a little bit.
Sean, obviously, I mean, that comment and that discussion there sits right at the centre of 90% of our conversation inside of the pilot medical review panel in how we advocate to advance the issue. How do you feel it would transform that process if there were a framework in place that stopped that roller door from shutting and kept a dialogue going and brought, I believe, a greater level of support around CASA to try and assist the pilot?
I think it would be phenomenal. I think, I see pilots regularly and they come in for their medical and they know they're not getting it. There are people who understand where they're at. Then there are people who come in expecting a medical and get their medical. That's not too much of a drama, but it's that middle component that I spend, hours per pilot trying to work through the issues with them. And I know, Kate, I know you understand this because you sit on this side of the desk in Nara doing your own pilots. So, I know that you understand the struggles of dealing with the regulator. I mean, I'm very excited in the fact that, for the first time in my short career in AVMed, I've actually got somebody in AVMed who's willing to engage with the community. This forum just blows my mind. And I've had people talking to me all day. So you're going to roast her? Are you going to roast her? And I'm like, God, no, I'm not going to roast her. This is our best opportunity we've had in years. And I'm just so excited for what you're doing and what you bring to the table. I think it's phenomenal. I can't speak high enough of you, Kate.
This just turned into a love fest.
No, it's not turned into a love fest because we're not going to agree on everything.
Well, no, we're not, and that's really important, that we are pretty pragmatic, and we do understand that a mature relationship is not about agreeing all the time, and a mature approach for the regulator is not just giving everybody what they want. We all know that. It is the mature approach is about talking about it and working through it, and still being able to communicate effectively through it, and God forbid, friends through the end of it. And I think that's just a really important thing that we're going to continue to do, is just to keep on talking about it and keep those avenues open. And there will be times that you hang up the phone to me and just say rude words, and I will do the same about you, and that's absolutely fine, because ultimately we're still going to come to work and we're still going to work with each other, and do these things effectively with each other. And I think that's pretty important. I do say to a lot of people, I'm not sure when this is going to wear out. I'm only new, so nothing is my fault yet. So you let me know when I can stop saying that. I figure maybe the 6-month mark, but I'm going to maintain that nothing's my fault yet. And it is early days, and it's it's that honeymoon period where we're all really lovey-dovey and it's all fabulous, and we're going to pee each other off, and that's fine. But I genuinely hope that is going to be water under the bridge, and we're going to say, oh well, gosh, you pissed me off the other day, can you not do that again? Anyway, moving on, let's just keep talking, and we will keep talking. And I'm aware of time as well. And that's probably an important thing for your membership. But this is not the only chance you're going to have to throw questions at me. Thank you for not roasting me. And maybe next time, now that we're through the honeymoon, you're going to actually smash me next time. Please don't. But we will have the opportunity to talk again. We will have the opportunity to meet. I will be back on your screen if you'll have me to talk about stuff. Maybe we'll talk about vaccines next time because we might not have time tonight. And we'll talk about long COVID and mental health is a really big thing for me in my world as well. And we'll talk about that. We'll talk about substances. We'll talk about alcohol misuse disorder. I'm okay. Thanks for asking. And all of that, this is not the only conversation we're going to have. And I think that's really cool.
It is, Kate. The best way to advance anything is to get everyone in a room and start talking about the problem. And I'm a huge advocate for talking. I get to do a lot of it, much to some people's disgust, but I think a debate and a dialogue is most certainly a healthy thing. It's how we thrash the issue out. And maybe it is a good time at the 56-minute mark to be able to say thank you very much on behalf of the board of directors of the Aircraft Owners and Pilots Association. Who very much appreciated you accepting the invitation that I put forward. And personally, I'd like to thank you as well. I know we've dealt with each other external to your role at CASA, and you were a fierce advocate in that position, and I don't imagine you're going to be any different in the role that you have. And in fact, it wouldn't be fun if you weren't. So I'm looking forward to that engagement, and I welcome you to come on the broadcast and hold us to account as well, because that's how we're going to work through these problems. We're going to identify the issues on both sides. To all the members who have contributed to the discussion, I know there's some of you out there that have got burning questions, and you would love to have put those questions in this evening and I guess sort of very specific and determined answer on it. I am going to do exactly as I've offered to do for Dr. Kate. I'm going to take all those questions and comments, I'm going to package them up, I'm going to send them through, and we might invite Dr. Kate to respond to those, and we can communicate to our members and we can start to work through what Kate is allowed to necessarily respond to. And if you're out there right now and you've got an issue that is in play with CASA AVMED and you need some support and you need some assistance in navigating your way through that, then what we really do encourage you to do is to reach out to us here at AOPA. So you can contact Sean.Runacres at aopa.com.au. You can send through a request to the AOPA Pilot Medical Review Panel. Dr. Sean Runacres heads up that panel and he will engage with you. And as he's already outlined, he doesn't get paid. He works entirely as a volunteer and gives up just an extraordinary amount of time. And I know, David, when you were working on the panel, the hours you ploughed into representing our members and looking after our members was just phenomenal. And so to the two of you, the membership thanks you for all that effort that you put in. But if you're out there in pilot land and you're having a problem, we really do recommend you get in contact with us. We've got some great expertise and experience within the organisation, and we've got great contacts inside of CASA to be able to advance those concerns and have those conversations directly. So thank you, Sean, and thank you, David, for joining us for the discussion and contributing. Thank you, everybody. Again, thank you, Kate. Thank you, CASA, for allowing this and not bringing the roller door down on it before we could make it work. I hope it's been constructive, Dr. Kate, and we can do this again. And with that, thank you very much, and we'll see everybody at our next AOPA Live.